नमस्कार. ही स्टोरी एक अशा कॅन्सर पेशंटची आहे ज्यांनी 12,000 किलोमीटरचा प्रवास केला फिजीहून सांगलीपर्यंत अशा शस्त्रक्रियासाठी, ज्यामध्ये लहान आतडीपासून मूत्रशयाची थैली बनवण्यात आली. चला याच्याबद्दल जाणून घेऊया. हॅलो मिस्टर इमॅन्युअल, हाऊ आर यू डूइंग टुडे मॉर्निंग?
Good morning. I'm doing quite well, thank you.
So, Mr. Emanuel, can you briefly just tell us a little bit about yourself?
My name is Emanuel Prasad. I come all the way from the South Pacific island of Fiji, and I live in the capital city of Suva. By profession, I'm an English teacher, and I teach levels year 9 to year 13.
Okay. Mr. Emanuel, as I understand that you chose to come to India for a medical procedure. Okay. So can you tell me what were the first complaints that you were having and when did it start?
In late 2022, I started having burning pains when I visited the washroom, and it wouldn't stop. So I was sent to the kidney hub, where they looked at patients with similar kind of problems.
Okay.
And I was given medication, but that could not work.
Correct. They probably must have given you medications for urinary tract infection. Assuming it's that.
Yes. They tried to treat my urinary tract infection through antibiotics and some other tablets.
Correct.
According to the tests, it showed that my kidney function was fluctuating from very good to very bad. That's what the doctor was saying, that my kidney function was going up and down, up and down. Last 2 tests came, so they found out that it wasn't the kidney, but then it was the bladder, I think.
Because you are still having the symptoms.
I still had the symptoms.
Correct.
So after that, I went to Miyot Hospital. It was during those tests that we were able to find out that there was some growth in my bladder.
You did an ultrasound, and that's when the mass was first detected.
So then I was put on medication again, and by that time I started bleeding. I had clots also coming out.
Oh, okay.
And it was in excruciating pain. Asked to go and see a urologist. Urologist decided to do a procedure called TURBT. And before the procedure, he told us that the tumor was growing bigger in size. He would go right up to the bladder muscle wall and do a biopsy. When the biopsy results came back, it showed that it was just a normal growth. He told me I was healed, and then I was not. But then the symptoms persisted after that a month later, and I was bleeding again and passing clots, and we did some more tests and more ultrasound. So after having those tests done, he found out that the tumor was progressing, and then he decided to do a TURBT again, and this time go right up to
The
muscle. He did perform the TURBT. When the results came out, it wasn't that good. He found out that the previous doctor hadn't done a good job, and he managed to take out all the tumors that were there and gave me some drugs to take after that.
What was the time gap between the first TURB and the second TURB?
It was about 6 months.
So 6 months delay caused the tumor to advance and reach the muscle mass.
Yes.
Okay.
And following that, he told me that I needed to undergo BCG therapy.
All right.
And he told me that the BCG therapy could awaken all the defenses in my body, and it could possibly kill whatever cells that were trying to. So I had 6 cycles of BCG therapy, passing urine too frequently, just at night time especially.
Okay.
So anyways, after the 6 cycles, doctor decided to do another biopsy just to see what has happened.
Correct.
And when he did the biopsy, he found out that the BCG therapy hadn't worked, and that actually the tumor had progressed to be cancerous up to the bladder muscle.
So can you tell me when was the first time that you spoke to the patient?
So I had an email actually from Mr.
Okay.
Emanuel Prasad and from Fiji. He was a case of bladder cancer which was diagnosed in Fiji. He was suffering quite a lot. And actually the email came saying that, I'm at a stage where I need supramajor surgery. And this is not done in our part of the world. And he was just in distress, and he just sent me all the details.
Okay.
So this was probably in the end of February or the beginning of the March.
This year,
Yeah.
2024.
Yeah.
Yes.
He was diagnosed as a case of bladder cancer.
Okay.
He's a teacher. He sent me all the details, and like usual communication, we told him this is what you have and we can help you out. And this is how the whole thing started.
So, sir, what was unique about this particular case?
I won't say anything unique about, but I think people who come from overseas with the bladder cancer present with a different presentations or a different scenario. Many times what happens is, first time the diagnosis of the bladder cancer has to be done in an appropriate way.
Okay.
I always felt that patients with the bladder cancer do extremely well. First chance is the best chance.
Absolutely, yeah.
So he went to the local doctor. I think they did the appropriate investigations.
Okay.
They found there is a growth in the bladder, which was causing him bleeding in the urine, which we call as a hematuria. Now, it's important that you need to find out what stage and what grade this disease is.
The TNM classification.
Yeah. It is done by doing sort of a cystoscopy, meaning looking inside the bladder,
Okay.
have an appropriate imaging.
Okay.
And nowadays we are doing some genetic testing also on the tumor which we remove.
Okay.
So this was initially diagnosed as a patient who has a bladder cancer which has not spread into his muscles. There are two types of bladder cancers. One which is called as limited to the wall of the bladder, which is called as a non-muscle invasive disease. And the second one which is invasive and has a potential to spread outside the bladder.
Correct.
And the third part is usually the disease which is spread outside the bladder. So the metastatic disease.
Yeah.
It's very important to make a distinction whether it is limited to the bladder wall or if it is going outside the muscle of the bladder or has a potential to spread. So sometimes the error is made in making that kind of judgment.
Okay.
And why this occurs? Because the first operation when you do has to be an appropriate operation where you remove the tumor and also go at the base of the tumor to differentiate the muscle invasive and a non-muscle invasive disease.
Correct.
For the first time, he was diagnosed as a case of non-muscle invasive disease.
Yes, in 2023.
Yes.
Correct,
If patient doesn't have a disease gone into the muscle, they will treat him with an intravesical treatment, a chemical, or an immunotherapy in form of BCG. This was assumed that this is a disease which has not gone into the muscle.
yeah. Correct.
Unfortunately, he suffered quite a lot. And after that, he had further symptoms. And when he was further evaluated, he was found to have the disease was into the muscle and it had gone to a muscle invasive stage. So there are two possibilities. Either this could not have been diagnosed earlier before, or it's possible during period of something like 3 to 6 months, a disease which was non-muscle invasive has gone into muscle invasive stage.
So, what would be your ideal approach for diagnosing something like this?
Who comes with a suspicion of a growth in the bladder or a bladder cancer, we go through all his details, we examine them clinically. We do a test which is called as a urine cytology, which gives an idea whether the patient has an aggressive disease or not. Very simple test, a urine-based test.
Right.
We also run some biomarkers on urine test and do imaging, meaning that whether that cancer is only limited to the bladder or spread to the kidneys and urethra or anywhere else. Next step which comes is doing an endoscopy, which is called as a cystoscopy, where we put the patients to anesthesia under sleep and actually not only examine the tumor, but we resect the tumor endoscopically. This is the most crucial step because that decides the fate of the patient. So the operation has to be complete. It has to be done by the expert, and that operation will give you a clear idea whether the disease is limited to the bladder or it has gone beyond the confines of the bladder.
Understood.
Once you have that distinction, it's a non-muscle invasive disease, you can save his bladder. If it is a muscle invasive bladder, you may have to sort of remove the bladder. So this distinction is important. This is how we approach the patients.
Right.
Like all other malignancies, PET scan has been well proven,
Correct.
but it has not come in the guidelines as of today.
Okay.
So far, we rely mainly on CT scan.
All right.
Sometimes we rely on MRI for local staging. But as of today, the standard of care is CT scan of the abdomen and pelvis and CT scan of the chest. You go to USA, I think many insurance companies even do not pay for PET scan.
Yes.
And they're expensive.
Even in this case, they did not.
But in our part of the world, I think thanks to the progress in India, the PET scan is available easily. It's not that expensive. So now we are actually recommending the PET scan for staging of the bladder cancer.
Right. Because it immediately tells you any other masses, any other places in the body.
Yes.
Has it metastasized or not?
Yes. Currently, standard of care is a CT scan The PET scan now, sort of within 2 weeks, you will hear from us when we give a recommendation to all of the globe whether PET scan should be offered or not.
He said there is no option but to do chemotherapy or chemotherapy as well as a cystectomy.
A radical cystectomy
Yes.
where you remove the entire mass and the bladder.
Yes, did some research and I didn't get good reviews about the procedure that happened to other people.
What made you choose India over New Zealand, Australia, or Singapore, which are much closer to you?
I have to pay thousands and thousands of dollars.
Yes.
I did not have that much money.
Especially after spending so much in
Yes.
Fiji.
They told me that I could seek treatment here in India.
Okay.
And I also knew of people, a lot of people who come to India for treatment because it is quite cheap. This is where I looked at 4 different places. They wanted around 40,000 Fiji dollars to have the procedure done.
Okay. In India.
So I did some correspondence with Dr. Khochikar, and he told us that the procedure is about 4.5 to 5 lakh, which was way cheaper than the rest. That was the first reason why we came here, because of the cost benefit was quite cheap.
Okay.
The second one was I was told that the service and the technology that was being used here was so advanced. There was everything in one shop. So that is the other reason why I opted to come.
Okay.
Yeah.
When you heard the cost the first time, did you have any reservations with respect to the level of medical care that could be received at this cost? Like, did you feel like if it's this cheap, it may not be up to the mark?
No, because I trusted our friends in New Zealand, told me that it would be 1/3 the cost of the procedure that the other hospitals, and they reassured me that the technology used here is quite advanced.
At
And the
UAIMS.
hospital itself at Ushakala Binar Institute of Medical Science, it was a new hospital with the state-of-the-art facilities. And
It's
that
the
I would get
largest
the best
in,
treatment.
in the region.
In
Yeah.
the-
So, what was the procedures that you have performed on this patient?
Certainly, he required sort of a cystectomy, removal of the bladder. We did a PET scan after coming over here, which luckily showed the disease has not spread anywhere else. But when we looked inside the bladder for his assessment, his urethral strictures, the prostate was involved by the disease itself. So he was not a candidate for making sort of a new bladder which is attached down to the sort of
the
the urethra,
urethra.
which is called as orthopedic bladder substitution. But anyway, he had a very good chance of cure because the disease is not spread anywhere else.
Okay.
So we actually made a new bladder from intestine and give him a bag on the tummy, which is called as urostomy.
To drain the urine.
Yes. This is a highly technically demanding operation. It takes about 6 hours to do the surgery. Anywhere you go across the globe. A lot of attempts have been made to reduce the morbidity and mortality of this operation. The complication rate of this operation is in the range of 30 to 40%.
That's really high, yeah.
About 6 to 7% can die within 3 to 6 weeks, perioperative mortality. 1/3 of the patients do come back in the hospital within 3 months, with repeated complications. Because it's an expensive, technically challenging, morbid operation.
Correct.
And you are actually creating a new organ made of an intestine.
Yeah.
So it's a technically demanding. Also, a lot of people across the globe have made attempts to reduce this morbidity. Our morbidity, perioperative morbidity, is less than 15%.
That's great.
Across the globe is about 30 to 40%. The readmission rate within 3 to 6 weeks after operation is less than 8%. And that has been achieved over the last 3 decades after doing more than 600 cystectomies. People have been coming all over sort of part of the world coming here to get the surgery done.
It's the experience of yours that counts as well as the facility and the advanced technology.
Absolutely. It's not only sort of a surgery because you require pre-operative counseling. Because, somebody who gets a new organ, and even if you get a stoma on the back, his quality of life post-operatively has to be important.
Correct.
The psychological trauma is something, a new life, adaptability to this new life, because you are going to move in the society with this kind of back.
Correct.
But even if you make a new bladder, by the time it gets a continence, it takes a little bit of oil. So it's not only the stress of cancer. Sometimes they get chemotherapy before or after surgery. And this sort of a new organ which has been created is quite a stressful thing for the patients. You require dedicated people, like a urological oncologist, who are able to deliver this optimal care.
I had actually done a research on this hospital,
Okay.
as well as I was given a brochure about Dr. Khochikar,
All right. Okay.
and I read some of his papers. I had listened to some of his videos.
Okay.
I was very, very impressed. He came highly recommended by so many top ranking officers into any other part.
Can you tell me a little bit about the process of contacting the authorities or the hospital in India, and then the visa and the process of actually coming to India for the process? How did you find that?
Well, the process was quite easy. I kept on informing Dr. Khochikar about my tests and the results through email.
Okay.
And he was very nice. He replied to me and he gave me suggestions on what's going to be done. So through the email, I was able to make arrangements with him. The visa process, it was quite simple. It wasn't difficult. I was able to get my medical visa at home in the Indian embassy. 2 days.
How much time it took for the entire process from you first deciding to have the treatment done at UAIMS hospital and for you to actually take the flight and reach here?
It was about 2 months.
And after coming here, how have you found your experience?
And when we came around about 3 to 4 o'clock, the reception worked so fast. It was like clockwork. They told me to go to see Dr. Khochikar. He saw me, we had a good discussion. Then I was taken to all the places to have the tests done.
No long lines, no filling forms, nothing.
No, actually they bumped everyone over and they let me go and have all the tests done. And that was really, really nice of them. And then immediately in the evening, I was admitted on this floor.
Okay.
All the hospital beds were full. So I was admitted on this floor in an air-conditioned room, a deluxe.
In Emanuel's case was, we were all geared up to do sort of, neobladder for him. When we went inside, the part of intestine, what we chose to make sort of a new sort of a bladder for him, he has a congenital anomaly called as a Meckel's diverticulum.
So can you please explain in simple terms what exactly is a...
So Meckel's diverticulum is a congenital anomaly. So it's an outpouching from a small intestine.
Okay.
Usually it doesn't give much symptoms, but if it gets infected, you have to go and excise that part of intestine. This is coming exactly in the mid portion of a part of intestine which I wanted to use it for either making a conduit or a new bladder. When you try and excise it, the blood supply to that segment gets sort of hampered. And the operation is likely to fail. We had certain tricks up our sleeves, so we could excise that also. We could save the blood supply of that piece of intestine and use the same part of intestine to make him a sort of an ileal conduit. So this was very unique in terms of Emanuel, because you take about 50 centimeter, and almost 1/3 of that portion is also covered by the Meckel's diverticulum. So what are you going to do?
So lost 1/3 of
that portion,
intestine.
but we could use that segment to make an ideal conduit for him. So I think he's lucky. He's walking home. Within 2 weeks, he's going home.
Now that you have had the treatment, okay, how are you feeling now? How has your experience been with respect to the level of care by the doctors?
The doctor, exquisite. The nurses, exquisite.
Okay.
The other people who look after us, like the mama and the mausi,
The housekeeping
the
staff.
housekeeping, wonderful.
Okay.
It's like staying in a hotel, and everything is done to hand to foot. They nursed me. They showed a very high level of professionalism in whatever was done. They attended to all my needs in a very, very quick manner.
Compassionate manner.
Yes, they were very loving. They are very kind, and I met the real Florence Nightingales here.
So from this experience of yours, if there's one message that you could give to people in your country or other country, what would it be?
It's the best facility that one can have. It's a super specialty hospital where all different kinds of doctors treat all different kinds of illnesses. I can tell the people without a doubt that I think this is the best place to come and have a treatment,
Okay.
because everything is provided. The costing is very cheap for us. The service is impeccable and very, very professional. I would encourage everyone to come to UAIMS. I would like to help the other people.
Yes, so that they can get the correct treatment at the right time.
Yes.
Because that's very important.
I have been
Yeah.
through the system now and I know what it is like.
Yes.
And I would never trade going to another hospital than this one.